Anything dealing with the face and neck, so we're gonna deal a little bit with the facial anatomy. Like knowing where certain bones are, like the maxilla or the mandible. Here's a tough one, nasal bone. Yeah, that's one you're here, right? Ear, the anatomy of the ear. Where is the outer ear, the middle ear, and the inner ear? What are the names of the bones of the ear? What's that membrane that vibrates back and forth? Tympanic membrane, okay. While we're talking about it, anatomy of the eye. The white part of the eye, the part that's adjustable for light, the retina, the sclera, the vitreous and aqueous humor. So, kind of mentioned this a few minutes ago, significant blunt force trauma to the face. Significant trauma to the face, you probably also have cervical spine problems, right? We're not talking a laceration, right? Something blunt force where their head, they got punched, they got hit, they, hit the dashboard or the steering wheel or the windshield, probably have a cervical spine injury as well. Certain specific types of fractures, like, what is this area around your eye?
Orbital.
Your orbitals. So orbital fractures. What's your giveaway sign for an orbital fracture? No, it's not raccoon eyes. Could be disconjugate gaze. What does that mean? They're a chameleon. Because we should have conjugate moving together, right? Not disconjugate. You mentioned diplopia, which is double vision, right? Seeing double. So the other one is the eyeball movement. Like if they could not move their eyeball up, probably broke up here, right? Because there's nothing for the muscle to pull. Or if they can't move it down, it's probably broke down here, nothing for the muscle to pull the eyeball down. So that's a hint that it's a orbital fracture. Those are kind of orbital or orbital blowout fractures. The paralysis of gaze, it can't go up or down. So it's something like, if you ask the patient to follow your finger and they can't follow it when they go down, when you point down, that could be a sign of an orbital fracture. Other facial fractures, like this guy, what's this? The zygoma, zygomatic bone, the cheekbone. What's the giveaway that that's the fracture site?
Flat.
It looks flat, not a nice little cheek there. Okay. Ear injuries, right? The outer ears, the auricle or pinna, right? If there was significant trauma to the ear, bad and disfiguring and disgusting as it may look, we still need to rule out other more life-threatening injuries. An ear got ripped off someone's head in a bar fight. Is that going to kill them? No, I gotta look for the more severe injuries. Don't get tunnel vision or what they call moth to candle syndrome. Oh my God, it looks so bad, and you missed something big, right? My old partner Scott totally missed something. It was, guy had motorcycle wreck and really bad angulated fracture, femur sticking up out of his leg. And he's like, looking at it. He's like trying to figure out how to address that, and he missed the fact that there's 3 ribs sticking out of the guy's chest. Like, the ribs were more important than the femur, right? What else? Dental emergencies, right? Somebody got their teeth knocked out. How do we preserve the tooth?
Milk.
Right, if authorized, we can put it back in, have a bite down, on it, put it in.
Milk.
Milk, don't touch which part?
The
crown or
roots.
the root? Don't touch the root, right? Don't try to wash it off or scrub it clean or anything like that. Where else might you find those teeth that somebody was in a fight?
The fists.
In their airway, it could be an airway problem, or it could be
In their fist.
in the knuckles of the person who hit them. So don't forget to check the other person too. If they're missing teeth, maybe it's stuck in the other guy's knuckles. What else? You have an impaled object. When can we remove it?
Only if it's blocking the airway.
Only if it's blocking the airway. So in the cheek, is that blocking the airway?
No.
It could be.
Well, yeah, that depends.
It could be, and that's an easily removable one, because I can actually get to both sides, right? Bandage or hold pressure. But I would remove it if it was impeding the airway. What if they had something sticking out of their neck?
Just stabilize it unless it's messing with the airway.
Yeah, well, even if it was messing with the airway, what am I gonna do?
Or glue.
I'm gonna stabilize it, and then what? I'll probably crike them. Right, so I don't really pull things out of the neck. So neck wounds themselves, any special dressings or bandages?
Occlusive dressing.
What? We're worried about air embolus. They always have to be airtight seals. There is a hazard if I bandage the neck too tight. Now, I never circumferentially wrap the neck, right? We'll go around and kind of do that under the arm to one side. But if it's too tight, it could put some pressure on the nerve, right? It could stimulate the vagus nerve, which would cause bradycardia. So if somebody's getting bradycardic after you bandage their neck,
Loosen.
it might be because you put the dressing on too tight, too snug. The fork fractures, 1, 2, 3, and 4. What was 1?
Right here.
Right, the mustache, yeah. 2,
Here.
you got the bridge of the nose. 3, the whole face basically. And 4, somewhere up on the front of it. So the common thing is wherever the fracture site is, below that everything looks longer, elongated, right? Horsey face, droopy. Okay. If for some reason you were not able to maneuver the airway or the mandible or the jaw, whether it was trismus fractures, and you needed to get an advanced airway, what would you do?
Crike.
Go right to the crack. Been waiting to say that. Burns, right? Burns to the air or upper airway, I should be very suspicious for if I see burns to the face. Singed hairs, soot in their nasal sputum. That's a big hint that there's an airway problem. What part of the face gets burned really bad? Eyelids, because they're so thin, you can actually burn them off. It's very thin membrane here, so eyelids. And that's thermal burns. What about chemical burns?
Yeah,
Right? If somebody got chemicals splashed in their eye, I don't care if it's an acid base or what, how long do I wash out? At least 20 minutes. All right, 20 minutes of irrigation. Make sure you don't wash it into the other eye. Bandaging the eyes. Why do I bandage both? Because we have conjugate gaze. I don't want just one, I can't, if I cover this eye, even though the other eye is moving around, this one is still moving under the bandage. You need to cover both of them. Contact lenses, when do we take them out?
Only
Chemical burns.
Only chemical burns. Right? So how do we put Morgan lenses in?
Like I
Basically just like taking contact out in reverse. I look down, go up, go down. What's the one key thing you have to have going on a Morgan lens first?
water.
Always make sure the fluid is flowing, constantly flowing. Otherwise it may stick to the eyeball. What could cause trauma to the trachea?
Punch to the throat.
Throat punch.
Throat punch, yeah. No. Steering wheel. We do get quite a bit of that, the steering wheel. Handlebars, but steering wheel is probably the more common. Airbags have helped minimize that, but not every vehicle has airbags. What's my goal for O2 sets for face trauma? Above 94. Person was not getting adequately oxygenated. Hypoxia could ensue, right? Hypovolemia or hypotension could ensue, right? With significant enough trauma. Which would kill them or kill their brain first? Hypoxia. How long does it take for the brain to start dying with hypoxia?
4 to 6 minutes.
4 to 6 minutes. Okay. Significant face trauma, we should be thinking not just spinal trauma, but also probably traumatic brain injury or, closed head injury, brain trauma. Common sign of a fractured nose,
Nosebleed?
nosebleed and
Deformity.
deformity, right, it's offset. Eye emergencies, what was that blood in the anterior chamber? Hyphema, okay, blood filling up the anterior chamber, and it looks kind of clear, you can kind of shine a light through it a little bit, that's bleeding into the anterior chamber of the eye. What would raise the pressure inside their eye that we should try to encourage them not to do?
Coughing.
Coughing, bearing down, any of those vagal stimuli. All right, what if they had specks or floaters in their eye?
Or retinal.
Retinal detachment, yes, is, I don't know if you've ever like, blew your nose real hard or something, you kind of see like little specks or, floaters. That's your retina partially separating, it's not a big deal unless it completely separates, usually very self-limiting and heal on its own. What was that eardrum called again?
Tympanic membrane.
Does that hurt when it ruptures?
Mhm.
Oh yeah, that's a very, very, very painful injury. And we mentioned it in this chapter, but it is not on the test, because we'll talk about it in chest trauma. If it ruptured the tympanic membranes, like a blast, we need to think about tunnel problems. All right, so that's 34.
No, nothing, I went.
35, right? 45 questions coming from chapter 35. The skull anatomy, as far as bones, where they are, not the face part, we're talking about the rest of the head, the skull part, and the spine, right? Like how many vertebrae are in the cervical, thoracic, lumbar, et cetera, et cetera. The different parts of the brain and what their functions are. Like where would you find personality? Frontal lobe. Where is hearing? Temporal. Where is vision? Occipital. Okay. The meningeal layers. DAP, right? Dura, arachnoid, pia. Other parts of the brain, not just the lobes, but where would your body regulate level of consciousness? Reticular activating system. What about mood? Limbic system, okay. Parts of the medulla control what? Breathing, blood pressure, heart rate, all the vital functions, yeah. What is an intervertebral disc? Intervertebral. The disc between your vertebrae. What does it do?
Cushions.
It's like a cushion, a little bit of a shock absorber, but if it slips, it could cause the vertebrae to pinch the spinal column, right? Spinal cord. What is a dermatome?
That's sensory sensation.
Areas that are of the body that are sensation, dermatome, and where they exit from the vertebral column, spinal column. What is a myotome?
Motor.
That's the movements. So there were 3 dermatomes I told you to make sure you know.
T2, T4, T10.
Armpit, which is T2,
2,
nipple line,
4.
umbilicus,
10.
okay. So no sensation below here, T2, T4, and T10 respectively. Couple of the book doesn't describe it very well, and I may have kind of skipped over a little bit. A bunch of nerves that exit the spinal column and then kind of join back together as a bundle. They call it a plexus, right? Like your brachial plexus or cervical plexus or anything. Solar plexus, yes. Your phrenic nerve controls your diaphragm. Where does it exit the spinal column?
The foramen.
Close.
C3.
3, 4, and 5 keeps the diaphragm alive. It comes out all 3 of those and then joins back together. That's why it's part of that plexus. So if somebody was not using their diaphragm to breathe, their fracture is probably somewhere around C3, 4, 5. What if they were using their diaphragm to breathe, but not their intercostals? T2 through T7 is your intercostal, so probably somewhere around T2, T3, it's not working because they're not using intercostals only, they're not diaphragm. So learning some of those myotomes or dermatomes can be important. Those are really about the only ones that show up on the exams, not just my exams like the state and national. What else? Difference between a primary and secondary brain trauma or a primary and secondary spinal cord trauma. Primary is what? Happened at the time of the traumatic events. Secondary is from? Swelling, edema. Infection. Hypotension or hypoxia. Right? Those four things can cause or aggravate spinal cord injury that causes secondary injury. Secondary injuries, if we correct the problem, there's a really good chance they'll get their function back. Primary injuries, it's done. You know, if a knife cut the vertebra or cut the nerves, they're not going to heal. What is ICP?
Intracranial pressure,
Intracranial pressure. And what is MAP?
mean arterial pressure.
And what is that mean arterial pressure minus ICP will get me? Cerebral perfusion pressure.
CPP.
CPP, the amount of pressure it takes to perfuse the brain. Okay. Our goal is to keep the brain perfused. So we're talking about brain trauma, where the brain may be swelling, the skull is still intact, all right? And they're starting to get herniation. So what signs and symptoms might we see when the brain starts to herniate? Okay, blood pressure is gonna go way up.
My cabinet.
Blood pressure, or I'm sorry, heart rate is gonna go down, and their breathing as the brainstem comes out gets irregular, follows some different patterns. We collectively will call that Cushing's triad or Cushing's, okay? So that's part of it. So when we see Cushing's, we're super suspicious for closed head trauma, traumatic brain injury. What is our goals? Keeping the brain perfused. So I want their blood pressure to be at least 90. I want their SAT to be at least 90. In fact, we should put high flow O2 on them anyway. I want to keep their Glasgow above
9.
the 90-99 rule, right? Get their blood pressure above 90, their SAT above 90, and their Glasgow as high as we can get, definitely above 9 if possible. What's decorticate posture?
That's towards the body.
Towards the cord, the cerebellum. Away, which one's worse? The cerebellum. Okay, so we've got Cushing's triad, and now they're starting to posture because the brain is herniating, it's pushing the brainstem out. And because usually, almost always, you get that uncle herniation, which is more one side than the other, you're going to see what?
One side dilate.
A blown pupil, right? That one side will dilate, right? So what do? Breathe differently for them. What are we gonna do?
So you want their capno to be on the lower end of normal?
Yeah, so for this case, if they're herniating, that brain is getting pushed out, is that good?
No.
No, they are FTD, fixin' to die, okay? I've seen this probably a dozen times in my career. And boom, they're decorticate posture, flexion. Then they go to decervant posture. And then nothing. And that's right about the time you're gonna go, crap, somebody start compressions, because they die. And it happens pretty quickly. But if you can get a BVM out and start doing what? Hyperventilating. So we hyperventilate when we see that herniation syndrome, right? That blown pupil, that posturing with Cushing's. What is hyperventilation? All right, for the adult, 20 breaths a minute, 1 breath every 3 seconds. And our goal is
Between 30 and 35?
between 30 and 35 on the capnography. Normal capno is
35 to
35 to 45. If I have to, I want to keep it on the lower side of normal, 35 to 40, but when I hyperventilate, I go a little bit lower, 30 to 35. It is a temporary fix. I can tell you, because I've done it, I've seen it happen several times. That person starts posturing, you start hyperventilating. About that fourth or fifth breath, they stop posturing because the brain's going back up into the skull. Because you've blown off some CO2, it constricted the vessels, it decreased blood flow to the brain. It is a super temporary fix. So I'm gonna hyperventilate until they stop posturing, we're good. A couple minutes later, they start posturing, we hyperventilate a little bit, we're good. This is temporary. This is to get them into an operating room so they can drill a hole in the head and relieve pressure. And no, before you guys ask, we're not gonna issue you guys IO drills to drill holes in their head. Not yet. So, capnol levels. What was DAI? Diffuse axonal injuries. What are we talking about? The axon. If this was a nerve cell, here's the body of the cell with the little dendrites that come in, and then here's the big long axon that goes out. This is damaged, right? Many of them throughout the brain are damaged. What damaged them? They got stretched, they got sheared, they got torn, right? Diffuse axonal injury. A lot of times from significant head trauma. Could be from concussions, could be from contusions, right? Could be from worse. They will rank them as mild, moderate, and severe. Forgive me, I didn't bring my book, but there's a little chart in the book that tells about the signs and symptoms for mild, moderate, and severe DAI, diffuse axonal injuries. Please review that.
Page 2005.
Page 2005, thank you, Art. Said that without even looking at the book. Ah, there it is. Much like different DAIs, different severity to head trauma, right? So that Cushing's triad, that mild elevated blood pressure, right? That mild closed head injury, what signs and symptoms?
Sorry.
Well, the breathing problem wouldn't be mild. That's going to be much more severe. So dizziness, headache, maybe some blurry vision. They start vomiting, we're kind of moving more toward moderate. When we start seeing the Cushing's effects, especially with the breathing changes, we're getting into the more severe. That chart is in the book too. What page are you?
2005.
Oh, man! Review those as well. What is auto-regulation?
Sort of like maintaining homeostasis.
All right, your body trying to maintain homeostasis, maintain balance, and this is, as ICP goes up, what happens to perfusion of the brain? It decreases, so by auto-regulation, your body raises blood pressure, which is then gonna lower heart rate. That's that auto-regulation process. But it's only gonna work so far. The different bleeds. Epidural, epidural hematoma, epidural bleed. Where is it bleeding? Above the dura, below the skull, between the skull and the dura. What type of bleeding? Arterial, venous, or capillary?
Venus. Capillary.
It's arterial.
Getting there one way or another.
Right, 1 in 3 shot. It's arterial, and that's because, bam, they get hit. It ruptured that artery. They go out, and then they wake up. What do we call it when they wake back up? The lucid interval. Right, so they're only out for a moment or so, and then they wake back up. No, I'm good. And it could be as little as 10, 15 minutes later, they go out again because it's arterial bleeding. It's pretty brisk bleeding. Are they going to get hypovolemic from bleeding into their brain?
No,
No. Why?
it's not
There's
enough.
not enough room. So if I found hypovolemic signs and symptoms, low blood pressure and things like that, what does that tell us?
Something else.
They came from somewhere else. Okay. So epidural is that arterial boom. They go out, they wake back up, and then go unconscious again, and they find out wake back up. So that's epi. Subdural, below the dura, above the arachnoid. That is venous bleeding, okay? So much, much slower, can take up to 24 hours. And that is the most common and actually has the highest death rate. No, I'm fine, but we have to watch for them getting really tired, mental status changes, not wanting to wake up. So we really should encourage them to go get looked at. And I think the stats in the book said it's 80 to 90% of head trauma is going to be a subdural bleed. So it's pretty high numbers, where epidural is less than 1%. Subarachnoid, below the arachnoid layer. It's going to be kind of diffuse, spread throughout the brain. Usually the worst headache ever. It comes on super suddenly, and they feel it everywhere. Because the subarachnoid, you're talking about the meningeal layers here. So epidural, it's actually outside the dura. It's not even in the meningeal layers. Subdural, yeah, it's meningeal, but it's not that bad. It's kind of localized. But subarachnoid, it's kind of diffuse. So it really irritates the meninges. So what other signs and symptoms would you see that suggest really irritated meninges? Think meningitis, neck pain, not necessarily fever, that would be infection. This is not an infection one. But that nuchal rigidity, that neck rigidity, right? Or the Babinski sign, or something like that. What is spinal shock? All right, what's neurogenic shock? A little different from spinal shock.
Distributive shock.
Okay, they're forms of distributive shock. Okay. Blood vessels dilate. With neurogenic, you get bradycardia. Right, with spinal, you don't always get bradycardia. It all depends on where the damage was to the spinal cord. Let's talk about spinal cord injuries. Anterior cord syndrome. What's the deficit? It's damage to the front of the cord, I know that. How about posterior cord syndrome?
Whatever the sheet.
Whatever the sheet says, whatever the sheet I need to study says, right? Right, impaired proprioception, right, pain, right, that's more posterior cord, anterior is more movement problem. Central cord. Central's a weird one.
That's the extremities.
You lose the arms, but not the legs. The person walk around, everything's just fine, but like they have weakness in their upper body. That's usually central cord syndrome. And then the other one that's really weird, Brown-Sequard. I lose
Sensation.
movement on one side and sensation on the other. Right, 'cause it's a half, like a right side or a left side injury. So definitely review those. Quite a few questions in this chapter about procedures for immobilization, rapid extrication, KED, helmet removal, right? And rule out immobilization or putting them on backboards, complications of them still being on backboards. Here's one. I don't think I discussed it earlier. Blood sugar. So I want you to think back to the neuro chapter. Strokes. Do we have anything different we did with blood sugar?
Treat under 50.
Yeah, instead of under 60, we treated it when it was under
50.
50. Well, guess what? For brain trauma,
The same.
we're gonna do the same thing, right? The book will actually say 45, but you can do under 50, it's fine. Why? Why do we not want to give dextrose solutions to people with brain trauma? It will increase ICP, it increases cerebral edema. It's gonna make the cerebral edema worse. So we don't wanna give a lot of sugar, because the sugar is gonna go into the brain, and it's gonna want fluid to move into the brain, making the swelling worse. So we just keep in mind, we'll treat it when it's not 60, but 50 or even 45, the lower side. Think just like a stroke. I'm not trying to overthink this stuff. Okay? Please read up on the immobilization stuff. I know it's like, oh yeah, backboarding, whoa, we got it. Like simple things. But what happens if the C collar's too tight? Loosen it. But what's the problem? What's the hazard? If it's not airway, what else? Could stimulate the vagus nerve and could also prevent
Drainage.
blood from draining because it's pinching on the jugular veins. And so what happens if it's too loose? It doesn't work, you know. So I know I had a couple people come up to me at various points during lab and say like, do we have to backboard every one of our patients in lab? I'm like, no, you have to determine if you need to backboard that patient or not, right? And you have to justify that to the instructor. So I don't want you to think like it has to be a backboard. You guys did some burn scenarios today. Like every group at least did one burn scenario. Did that person need to be backboarded? No, right? The face trauma. Maybe, maybe not, depends on which scenario you did. The laceration, probably not. The broken jaw, probably, you know. My point is, you need to think. I'm gonna try and be a little more eloquent than Instructor Tyree, okay? You guys are so much closer to paramedicine than you are EMTs. You guys are paramedics, right? And you learn all these cool things, and you wanna do all these cool things, and this happens every year with every class, so I don't want you beating yourselves up too much. Okay, that we taught you all this cool crap, you wanna do all this cool crap, and now we're like, don't overthink it, right? Don't overanalyze it. So it's just that, I don't want you to overthink it. I want you to be aggressive. If you're not sure, I want you to go ahead and do it, but I don't want you just doing it to do it. I want you to think, okay? These scenarios are not meant to be ungodly hard, but I will be brutally honest, because we're gonna have a national registry up here on December 7th for you guys. The scenarios you saw in lab today, if I had to put them on a 1 to 10 scale of difficulty, I'd give them about a 5 or a 6. Everybody that's done national registry scores their scenarios at about a 2. A couple people, I know Luna did it once, and I think you're the only one in here, role played as a patient for a different group doing national registry. How hard were those scenarios?
A 2.
A 2. There are, I kid you not, when it's like, hey, it's grandpa, he's had this really bad headache, and now he's all confused, and his face is all drooped on the left side, and he suffers from high blood pressure. What do you think?
Give him dextrose.
It's appendix, right?
Give him dextrose.
But like, I mean, they are so uber straightforward. We're not trying to throw monkey wrenches or curveballs at you guys here, okay? I think you're starting to realize any mistakes that are being made, probably because you goofed on something, whether it was, you know, oh, I'm gonna do CPAP, but the blood pressure was